It's so good to see you all. Thank you for joining us. Happy Thursday. As always, I'm so excited to join with the one and only Ravi Jiha and to go through a case and learn from the wisdom of everybody on this call, on this Zoom call. As always, it's not a VMR without a case presented by one of you awesome people and discussed by you awesome people. So please volunteer a case to present. Please volunteer to sit in the lukewarm seat with me and Robbie. We'll have some fun. As always, preferably we would love to have at least one discussant who identifies as a woman. In the meantime, I one of my favorite things is just to learn from Robbie. So I'm sure I'm gonna learn a lot from his reflections. So RG, hi.
Hi. I think I should stop paying you the $5 to throw my way.
It's $10 actually.
Yeah, oh, I'm sorry. Your price is going up, huh? That's because the quality of the reflections is plummeting. I get it. I get it. That makes sense to me. Good morning, good noon, good afternoon, everybody. Welcome to VMR. We would love to nerd out with you and can't wait to do so. And in our usual traditional fashion, we'll reflect on our case yesterday, which was a masterclass presentation by a VMR legend, Fernand, and discussed by Staff Zavin, and frankly, an outstanding discussion by somebody who I see here in the chat, Mario, and I'm not sure if our other colleague from yesterday is here, but if you are, that was absolutely a wonderful discussion. And I learned so much from it, and there's so much to discuss. But the dominant feature of the case was abnormal bleeding, although actually the patient went into a massive surgery before that even was a problem, which we'll reflect on at the end. But let's start off with a philosophical question, why don't we? Why do people bleed? Why do people bleed? There are 4 reasons why people bleed, but I'm going to ask the chat a harder question because, come on, it's the VMR crew. No way. Oh, the most exciting message in the chat just popped up. My dear friend Simona's case. And that is just, oh, okay. I want to pay you $5 for this reflection, Charmaine, because I think the energy from Simone is going to make it higher quality. So why do people bleed and evade our detection on the CBC? Oh God, okay. You know, I am an attending, but I can't be dishing out $5 here or there. But Simone, oh, 50 for you. Okay, yes, 50. Why do people bleed and evade our detection on the CBC? So please, if you're in the chat, I would love for you to type your answer. Why would somebody have bleeding problem and yet it not show up on our labs, on our platelet count, on our coags? Oh, Anne-Marie on fire. And I will now mute the chat and share my reflection and then come back to it and we'll poll the crowd. So the fundamental issue with bleeding is to recognize that you need vessel integrity to bleed. And vessel integrity is compromised most commonly by trauma, but is compromised by other things as well. Things like scurvy, which is rare and esoteric, but more common things like venous hypertension or malignancy when it forms bad blood vessels. So vessel integrity is fundamentally the most important reason why people bleed, because people bleed most commonly because of trauma. That is true for probably every single one of this person on this call. When you've had minor trauma, you've bled. And it's not because you've had coagulopathy or thrombocytopenia or von Willebrand's deficiencies, because you had vessel integrity compromised. But outside vessel integrity, what else could be happening? Well, remember that there are really 3 fundamental features to clot. One is von Willebrand's factor sticking out into the blood vessel. 2, the platelet hanging out and dancing with von Willebrand's factor. And then 3, the coagulation cascade. And the truth is, when we study the clotting, clotting and bleeding, we only have access into the platelet number and the coagulation cascade number. So it just so happens that outside trauma, quantitative issues with platelets and the coagulation cascade account for the vast majority of bleeding. But really, bleeding is a 4-pronged issue: vessel integrity, von Willebrand's factor, platelet issues, and coagulation cascade issues. Okay, so let me show you this visually. People bleed because of, are you guys seeing my screen? Are you seeing the bleeding screen? I can't tell. Okay, thumbs up from the one and only $5 richer, Charmaine Shikarcha. Excellent. So Yeah. Bleed because of a coagulopathy, which is quantitative or qualitative. These are some reasons why it will not show up on the CBC. Quantitative platelet issues and qualitative platelet issues. Vessel integrity, usually trauma, or von Willebrand's factor, which usually does not show up on the coagulation panel, but can. Yesterday, we had abnormal bleeding, and we were like, what's going on? And the PTT was the issue. The patient had an isolated, prolonged, markedly prolonged PTT. Now, why would that happen? Why would that happen? Why would that happen? This is on the website, uploaded by the one and only Simone, who's here presenting a case. Thank you. Why would you have an isolated elevation in PTT only? Well, the PTT arm of the coagulation assay studies the function and activity of 8, 9, 11, and phospholipids. Okay. Phospholipid disease usually results in thrombosis. Factor 11 disease is actually very mild and very rarely results in bleeding. And usually isolated elevation in PTT is either factor 8 or factor 9, with factor 8 being much more common. What is factor 8 deficiency? In kids, it's hemophilia A. In adults, it's an acquired inhibitor. Now, why would an adult get an acquired inhibitor? Most often, it's from an autoimmune disease or a malignancy. It's the same reason we make antibodies for anything: lymphoproliferative disease, lupus, pregnancy, so on and so forth. But we learned from Fernand yesterday that sometimes surgery can trigger the formation of an acquired factor 8 inhibitor. So the journey of yesterday's case was, a patient's bleeding too much. Where is it? Is it an abnormal vessel? Is it a coagulation cascade issue, a platelet issue, or a von Willebrand's issue? Our insight into this problem is through lab assays which look at coagulation cascade and platelets. Platelets normal, isolated PTT through the roof. So we went the PTT route. What 4 things cause an elevation in PTT alone? Factor 8, factor 9, jump, go to factor 11, and then make contact with phospholipids. Phospholipids are only really entertained when there's thrombosis. Factor 11 is very benign bleeding. Factor 8 or 9. Factor 8 is much more common. In adults is usually an acquired inhibitor. And that's where we learned yesterday from our dear friend Fernand, who taught us so many things about mixing studies and peptic ulcer disease and duodenal perforations. And for more, you should totally listen to that episode. Okay, I've been not paying too close attention to the chat, so I'll pass the mic to Charmaine to introduce our friends who may or may not be joining us. And if you haven't volunteered yet, you just made me sad. That's okay.
I know. That reflection made me very happy, and then no one wanting to discuss with us made me very sad. So I'm very confused right now. That was awesome, Robbie. I don't know what I would do without your schemas, friends.
Oh, you would be so happy, and you would be poorer though, but you would be happy.
Travis is asking you for your Venmo. Oh, awesome, Kirtan. Thank you for volunteering. We need one more, friends.
In the meantime, Simone, do you want to introduce yourself?
I would love to, Robbie. Thank you for the opportunity. Hi, friends. I'm Simone. I am a family medicine intern at UCSF in San Francisco General. That's really all I have to offer.
Lies. She's a complete boss lady.
Oh, yes, I'm a complete boss lady. I totally forgot. Thank you, Charmaine.
Right now it's recorded on tape. We should totally cut everything else out and only upload the section where she says that, okay? Everything else is less relevant now.
Exactly. Oh, you just made my day, Simone.
And Kirtan, I know you were here yesterday, but I got to tell you, there are a lot of new faces and voices. Can you please reintroduce yourself?
Yeah. So myself, Kirtan Patolia. I am a final year medical student from BJ Medical College in Ahmedabad. It is situated in the western part of India. I just discussed 2 cases in a row. It was extremely exciting. First with Dr. Aaron, and then yesterday with Steph and Zeven, and It was amazing.
I didn't see your name in the chat, and I'm so delighted. Your discussion yesterday was masterful. Thank you for coming again.
Yeah, thanks.
So excited to have you. I don't know if you can live up to Aaron and Steph and Zalvin, but we will do our best, Kurtan. We will do our best. Oh, yay. Matthew, do you want to unmute yourself?
Hi, I'm an emergency physician from Montreal, Canada.
Awesome.
Yeah, I've been following VMR for a little while now, improving my medicine day to day. Most of what I do practically is trauma. So I feel like my medicine is slowly degrading. So I found VMR to be an excellent venue to keep my skills up.
Oh my gosh. Complete boss. Thank you so much for joining us. We have much to learn from you. I have no doubt. Oh, we have a crew, Robbie. Let's get started, team. Robbie, do you want to take the first aliquot?
I missed your voice. I really do. And you might have to run. So why don't you take the first round?
Sounds great. Kurtan, do you want to tag team together?
Yeah, it will be great. Yes.
Perfect. Simone, whenever you're ready, friend.
Okay, and for whoever is scribing, I notoriously speak much too quickly, so feel free to slow me down. Okay, so we have a 42-year-old man with a history of ESRD on HD, opioid use disorder on methadone, who presents with weakness and symptoms of volume overload. And on arrival, he's found to have a glucose of 39 on his arrival VBG prior to receiving any interventions. A little bit more. He had been at the hospital 3 months ago for about a month, during which time he had bacteremia, which was complicated by multi-joint osteo. During that time, he was started on methadone and was receiving weekly HD. And during the majority of that hospitalization, his blood glucoses were normal. However, towards the very end, he began to have persistent asymptomatic hypoglycemia to about the 40s, which had been noted but not worked up at that time.
Oof. Simone, can't wait to tackle this with Kurtan. So, my friend, we got lots of information. What are your initial thoughts hearing the information?
Yeah, so it looks very fascinating and promising. First, to begin with, that this patient has ESRD. Now, my first point in this puzzle will be that why the patient has ESRD. I mean, the etiology of ESRD can give us more clues about why this patient may be having hypoglycemia. I mean, whether this patient is a diabetic or not. If he is diabetic, then whether he is on insulin or any other medications, that's why he is developing hypoglycemia. Another fact, that whenever we talk about hypoglycemia, we try to divide it into the etiologies, like whether it is iatrogenic, whether it is metabolic, whether it is toxic. And let's say if it is metabolic, then we know that renal dysfunction, hepatic dysfunction, both of them are sites of gluconeogenesis. So anything which can cause end-stage renal disease or cirrhosis can present as hypoglycemia. So it will be interesting to see that what is the driving force for ESRD. Now, regarding the opioid use, I mean, is that it? The patient is taking opioid and that's it? I mean, what if the patient is also consuming alcohol? And we know that alcohol can also cause hepatic dysfunction. Alcohol itself can cause hypoglycemia. So hypoglycemia has got multifaceted approach. And from what information we have now, I think that unless new information comes in, we should approach it in a broad manner and then we can zoom in on the final possibilities. So Sharmin, can you help me? What else we need to ponder on?
Woof, brilliant, my friend. That was fantastic. I am right there with you. So I think like honing in the end-stage renal disease was actually really, really key, and linking it to like decreased gluconeogenesis that is a risk factor for hypoglycemia. That was absolutely brilliant. I don't have much to add, so I'm just gonna share how I think about hypoglycemia. And my first step is always like, especially in someone who initially, like maybe during the last hospitalization wasn't as symptomatic, then is this a case of like a mimicker of hypoglycemia or like a pseudohypoglycemia? So we usually think about like, peripheral vasoconstriction, like people with end-stage renal disease, if they have like like peripheral vascular disease as well, that could be a reason for like finger stick glucose not being accurate. That's usually mitigated by getting a basic metabolic panel and the lab. So we assume like the glucose of 39 or the previous 40s were actually real basic metabolic panel, but that's something you always keep in mind. Delayed sampling processes, or for whatever reason, if you have like really elevated blood counts, like elevated white blood count, red blood cell counts, then those things can also cause pseudohypoglycemia in the sample. That being said, that's our pseudohypoglycemia. This is real. So let's, especially in someone who is like maybe coming in with like weakness, the volume overload we can maybe attribute to the end-stage renal disease, but just focusing on the hypoglycemia, and I'm just gonna table the weakness for now. Again, like weakness is always talking about, is it like an acute muscle weakness, or is there just asthenia, or like maybe the patient is like hypoglycemic and that's why they feel weak. So I'm just gonna keep tracking that. And when it comes to hypoglycemia, usually you think about whether it's an insulin-mediated process or non-insulin. And Kurtat, you were just brilliant in thinking like, hey, this patient is sick, but doesn't really, this patient has like chronically sick, but we want to usually with like insulin mediated processes, they might not have as much like chronic ill. So like hypoglycemia is the one and only issue, versus like with more chronic conditions and like with the background of like people being more sicker, they can have usually like the hypoglycemia is not the number one issue. There's number two, number three, number four. So I think in this person is warranted to both include insulin-mediated and non-insulin-mediated processes. And as you mentioned, this person has a lot of risk for non-insulin-mediated processes. Like, you mentioned like PO intake, like if your patient is consuming a lot of alcohol or not drinking, eating as much, decreased gluconeogenesis, right? Like liver disease or kidney disease in this case, or any reason for having increased consumption. This patient doesn't seem quite like septic, for example, but something to keep in mind. Is there any infection brewing or any like endocrinology or medications as well? A lot of like medications like typical beta blocker especially is the one that comes to my mind. And when we think about like insulin mediated, the C-peptide is what was going to help us determine usually is a lab to get when people are hypoglycemic, to say like, hey, if this is more endogenous or exogenous etiology of it. And so it would be really informative. And say common things being common, if this patient have end-stage renal and diabetes, a lot of the time is just like insulin doesn't get excreted as much in people with end-stage renal. So if the patient on the med list there's insulin and he has end-stage renal disease, that tends to be the most common cause of hypoglycemia, especially if the patient has diabetic. We don't hear that in this case. The last thing just to make note of opioid use disorder, it's, substance use disorder, like any other disorder, like your diabetes, is a chronic medical issue. And a lot of the times it has exacerbations and it has a difficulty managing it, even if the patient is on methadone. So just being open-minded and asking patients questions about like, hey, has there any other substances that they've consumed that might be laced with anything else, is another possibility to keep in mind. And, the patient has underlying osteomyelitis. So if there's any bout of sepsis originating from that, is another reason. So I'm like really, really curious to get some more information and see what happens.
Fantastic. Okay, this next aliquot will take you through the rest of the HPI and the rest of the history. So brace yourselves. So on the day of admission, the patient reports that he woke up feeling like he just couldn't get out of bed and that his legs would buckle under him if he tried to walk. He says that he's been feeling weaker recently and that his last meal was at 3 a.m. last night, and you're talking to him at 11 a.m. in the morning. He does endorse that recently he's just been eating less because he's been fearful of becoming volume overloaded. And he states that he occasionally feels hungry and sweaty, but it's not consistent, and he never has any tremors or any confusion. Overall, his weight hasn't changed since his discharge 3 months ago. You dig into his chart from his last admission and find that at that time, his lowest blood glucose was 42 at bedtime with a normal insulin level and an elevated C-peptide. And for review of systems, he denies fevers or chills. He's had unintentional weight loss in the course of multiple years, but none in the last 6 months. Like I said, no tremors or sweats or confusion. And he does endure several days of diarrhea and weakness. Okay, on to his past medical history. He's got ESRD secondary to amyloidosis. He's been on HD since 4 months prior to this admission, and he has been going regularly 3 times a week. For his opioid use disorder, he's been on methadone since his prior admission, which has been gradually up titrated, and he's currently on a dose of 130 milligrams daily. He has a history of HCV, but viral load is 0 at this time. And in terms of his recent hospitalization for MRSA bacteremia, they achieved most of source control. There was 1 abscess left, which was too small to tap, but he did complete 6 weeks of outpatient VINC, and he has no history of diabetes. In terms of his past surgical history, he had a left shoulder washout during his last hospitalization for osteo and septic arthritis, and he's had a tunnel line placed multiple times and removed. His medications are calcium acetate, nephrocaps, sevelamer lokelma. He's on Lasix, 120 milligrams daily, levothyroxine, and methadone, 130. He has no allergies. His family history is non-contributory. And socially, he is unhoused, but he's been living at medical respite since his discharge 2 months ago. In terms of his opioid use disorder, he used to use intravenously. More recently, he had injected subcutaneously and using intranasally, but he is currently in recovery on methadone and hasn't used since he's been at respite. He smokes half a pack of tobacco a day and does not drink alcohol. I'll stop there.
Oof, a lot to digest, and I'm so excited to have the expertise of my colleague and friend Matthew. Please let us know where this took you and what insights you have in general, and then of course from the acute setting in the ED where you work.
Well, I think we just got his meds list, so a lot of potential causes for hypoglycemia. It's being ruled out there. Still, we know his current medication. We don't know what he took in the recently, so I would want to review that. Once, like most common things, is probably medication-induced hypoglycemia. Once that is ruled out from a acute care setting, the second thing I usually think about is that adrenal insufficiency. So gonna want to review his medication list, see if he was on glucose corticoid recently. And the other thing that we've been seeing more and more frequently in the past recent years is with the opioid epidemic, some people are developing adrenal insufficiency secondary to their opioid use disorder. So that is something I would keep in mind. And we don't have vital signs yet, but if he has any sign of instability, I would just cover empirically for that possibility while we're working him up. The other question is does he have a liver disease? That would change the whole differential diagnosis. And the other thing to work up in parallel to trying to figure out the cause of his hypoglycemia is he septic? Like just seeing his past medical history, his recent past medical history, as well as like him being on the HD, being an IV drug user, like the chance of him being septic at any point is died is just extremely high. So I would be looking very hard for a septic source. And again, we don't know his vital signs, but if he has any signs of instability or anything, I would cover him empirically. So these are my thoughts at this point.
I love it. I think you're teaching us something very important, which is we have an approach for hypoglycemia that's systematic, but in the acute setting, what are the emergent causes? So if we make a schema not based on physiology, insulin or not, but rather what's an emergent cause and what's not. And I think, you know, the emergent causes really are sepsis, adrenal insufficiency. And, you know, I think that sulfonylurea causing hypoglycemia can be pretty severe because it's so deep, and sometimes drugs are laced with long-acting sulfonylureas that can push a patient to having persistent refractory hypoglycemia. And so that checklist of like, okay, well, what's life-threatening? Sepsis, adrenal insufficiency, and sulfonylurea overdose is really helpful, and probably the most practical way to think about hypoglycemia in the first 10 minutes. And I love you reinforcing the overlap between opiate use and hypoglycemia. You know, the most notorious opiate linked to hypoglycemia is the partial opiate of tramadol, which has been common enough that we stuck it on the schema for the clinical problem solvers. But, you know, methadone has been associated with hypoglycemia, but I think the most robust association is what you described, which is this poorly understood association with central adrenal insufficiency. So it doesn't affect the adrenal glands so much, the opiates, but rather the pituitary and the hypothalamus. And I agree with you. I think that's the key question. Is this patient septic? Do they have adrenal insufficiency? And then we can think about everything else afterwards, postulating on the possibility of opiate-induced either directly or opiate-induced adrenal insufficiency. And, you know, liver disease, we know the kidneys are down. So this patient's at risk for getting hypoglycemia from kidney dysfunction. And the question is, what's going on with the liver? And if you play the game of studying liver plus hypoglycemia, the simplest explanation is just like you said, just like Kirtan said, that there's reduced glucose stores, and so gluconeogenesis is impaired. The less common mechanism, which is fun to know about, is that HCC, which may develop in cirrhosis, has a rare association with secretion of IGF-2, which is another fancy cause of hypoglycemia. But I agree with you. Practically, is this patient septic? Does this patient have adrenal insufficiency? And should we be on guard for sulfonylurea, which might prompt more aggressive glucose resuscitation and the initiation of octreotide in the ER, which I've actually seen happen. But I will pass the mic back to Simone to give us more information.
Okay, great. So in this aliquot, I will give you his exam and the initial management in the ED. In terms of his vitals, temperature was 36.3, heart rate 98, respiratory rate 18. His blood pressure was 136/96, and O2 was 98% on room air. Generally, he was a thin man in no acute distress. His neck had no goiter and no enlarged thyroid. His lungs were clear. His heart had a regular rate and rhythm with a hollow systolic murmur. His abdomen had normal bowel sounds. It was soft, non-distended, non-tender. His extremities were warm and well perfused. He had no edema. His neuro exam was completely normal. He was ANO ×3, no sensory motor deficits. His skin was warm, dry, and not sweaty. And in terms of psych, he had a normal mood and affect. To give you the details of this initial VBG, his pH was 7.29, CO2 55, bicarb of 26.4. His K was 8.2, and his glucose was 38. He then got 10 units of insulin after the glucose of 38, 10 units of insulin, D50. His blood glucose improved to 205. And then over the next 4 hours, his blood glucose kept going down. He got about 4 amps of D50 over the next few hours, and then went to dialysis. And I'll stop there before giving you his complete labs.
Kirtan, go ahead, my friend.
Yeah, so lots of interesting things going on. Now, if we tackle the few findings in HPI, which emerged after we talked, that the patient has been eating less due to the fear of gaining weight. Now we can define that as some sort of anorexia kind of thing. And then you add that to the fact that the patient has been feeling a little bit weak, the patient has been buckling. So it makes me wonder that what is the cause of weakness and how we can link that to opioid use disorder, how we can link that to hypoglycemia. So as the Rabi mentioned, and as the Matthew discussed, that what if there is a component of adrenal insufficiency, whether it is central or primary, that's different thing to talk. And now let's say if that is the case, then they can lead to hypokalemia, and hypokalemia can cause this weakness. Apart from that, the patient has also been having diarrhea, and we know that adrenal insufficiency can even cause diarrhea. And now another important thing, that the patient has past history of amyloidosis. So now it would be interesting to consider that what kind of amyloidosis are we talking about? Is it the light chain amyloidosis? It is the chronic amyloidosis, the one associated with serum amyloid A type. And as the Matthew discussed, that opioid use is a chronic disorder. And we know that opioid use comes with lots of infections, as the patient has been having bacteremia, multiple and osteomyelitis. So what if the serum amyloid A is accumulating and we are getting amyloidosis from that? And amyloidosis can infiltrate the pituitary. Amyloidosis can even infiltrate the adrenal glands. And talking about the pituitary dysfunction, pituitary also secretes thyroid hormone and growth hormone. So it will be interesting to see what is the endocrinologic axis, because even the deficiency of growth hormone and thyroid hormone can be asymptomatic in some way, but they can be contributing to hypoglycemia to make it worse. So it will be interesting to see how the endocrinology picture looks. And apart from that, I think they have got it. I mean, they are on the right path. It seems like Rabi and Matthew have got it. So let's see what else we can do.
Brilliant, my friend. I love to talk about thoughtful about amyloidosis, and amyloidosis can infiltrate so many and have like complications. There's so many different organs that have the complications of that. That was absolutely brilliantly said. And yeah, I don't know if I can make too much progress in terms of like our diagnostic journey. Based on, I think, like what Robbie and Matthew were discussing was absolutely brilliant about what is our known misdiagnosis when we first meet a patient with hypoglycemia. And in terms of like the exam, one of the things they mentioned was like kind of the septic physiology, right? I'm a little less concerned about that, just given the patient's stability and vital signs. And the holosystolic murmur grabs my attention in the back of my mind. One thing that I've always been humbled by is kind of like a subacute type of low grade, a little bit of endocarditis that, especially in the setting of like osteomyelitis, like some strep species, that you don't get your staph bacteremia, but you can get, you have like a more low grade, people come in with like worsening back pain, osteo, and concern for endocarditis. So if this is the holosystolic murmur is new for the patient, something that I would want to get echo, and even though it doesn't scream sepsis to me with the vital signs, is something to don't underestimate in someone who has end-stage renal disease, who've had osteo in the past. So that grabs my attention, and the patient is not, it doesn't appear volume overloaded based on this exam with no edema. People can hide their fluids in different places. And coming to his VBG, he's a bit acidotic, and with a K of 8.2, I'm always humbled by how high sometimes end-stage renal disease can tolerate of the potassiums that they can tolerate. So in someone with end-stage renal disease, I feel like getting an ECG is quite informative to look for any changes with the hyperkalemia induced. And like, it's also interesting that the treatment for hyperkalemia, if you're concerned about, you want to give calcium to stabilize the membrane, and it's insulin, right? Insulin works great in my experience. It works better than beta agonists. So the danger of that is someone who is already hypoglycemic, you're giving insulin, and someone who's end-stage renal disease and the kidneys cannot excrete it as well. So this is the patient that actually you want to monitor way more closely for a longer period of time, and sometimes they actually require a D5 drip because he's already hypoglycemic, and if you add another insult by giving him more insulin. I would also be curious as to why, if this K is way higher than his baseline, why is it that? Did he miss any HT session? Is there any underlying pathology driven that as well? So those are like kind of the question that I'm grappling with at the moment. I'm excited to hear more of the workup, as you mentioned, to get a little bit more data to see what pops up.
Great. So his CBC, his white count was 5.4, hemoglobin 10.6, hematocrit 35.6, and platelets 175. His BNP, these are the next morning's labs, by the way. His BNP now after dialysis, the sodium is 133, K is 6.2, chloride 95, bicarb 28, BUN 48, creatinine 5 at 4.54, and his glucose is 62. On recheck 2 hours later, his glucose is 37. His LFTs are AST 31, ALT 29, alk phos 138. His total protein is 7.2 with an albumin of 3.8, T-billy of 0.4, D-billy of 0.2. He had a normal lipase. His TSH was 7.74. His T4 was 1. He had a total insulin level of 4.7 and a C-peptide of 6.7. That's a normal insulin and an elevated C-peptide. His beta hydroxybutyrate was 0.17. His sulfonylurea screen was negative. His AM cortisol was 8.9, which is within normal limit for that time, the time it was taken. And his blood cultures returned 1 out of 2 positive for streptomyces oralis.
All right, Mathieu. Give us some more, please.
So even with the normal cortisol level, I'm still suspicious of adrenal insufficiency, especially since I was taking at the same moment as he was hypoglycemic. So theoretically, I would have expected the cortisol level to be elevated if he was responding adequately to his hypoglycemia. So I'm still keeping that in mind. The other thing is that his super high K when he arrived could be a combination of his renal disease plus adrenal insufficiency, with both would have conspired to give such a high potassium. The good news with that potassium, I'm just like coming back to his lab when he arrived. The good news with that potassium of 8.2, if it's from a combination of adrenal insufficiency and renal disease, and like we don't have a bicarb on arrival, but if his pH was 7.29 and with a CO2 of 26, his bicarb was probably extremely low, but it was probably all hyperchloremic acidosis, or most of it was probably hyperchloremic acidosis. So you know that if you put him on a bicarb while waiting for dialysis to be set up, you're probably going to be able to drive your potassium down. Like you have 2 ways to act on that potassium, with 1, the insulin, and second, it's probably going to be responding pretty well to a bicarb drip. So these are my thoughts at this point.
I love it. I think that we always have to analyze every lab test in the context of what's going on. And a K of 8.2 in the context of kidney disease is easily attributable to the kidney disease. But the question is that sufficient? With the bicarb being relatively normal and the patient having not, at least as far as we know, missed dialysis, why is the K high? Should we be looking for another cause like cellular lysis from a malignancy, or more parallel with hypoglycemia, adrenal insufficiency? And I love that you said, again, let's take the context of the cortisol, 8.9, in the context of he's ill, and we'd expect it to be higher, but it's not. So what does that signify ultimately? Could this be adrenal insufficiency? I think that's very, very wise. It's the presence of streptomyces in the blood is a diagnostic of diagnosis of bacteremia. And the question is this endovascular infection and endocarditis, which is very, very important to study. But I would say the question is, what is the biggest abnormality here? And that we have to pause and reflect on what you said to start. You said the most emergent causes are sepsis, and we have reason now. We found an infection. Could it be at play? The other most morbid cause is adrenal insufficiency, but we can't ignore that either, because the cortisol is not high enough in this context, and certainly cocentromin simulation test would help us. But the most abnormal finding to me in the context of this illness is the C-peptide elevation. When somebody's so hypoglycemic, why are they making a normal amount of insulin, and why are they making C-peptide? Those should be completely suppressed. They should be, the pancreas should be asleep. And so yet, why is it awake in this context? And I think because of the number of abnormalities we're tabulating, we have to keep track of all hypotheses. Is this sepsis? Is this renal insufficiency? And then what's going on in the pancreas? And so why would the pancreas do this? There's a long list of reasons. I think, in no particular order, that the patient has taken a sulfonylurea, and that has stimulated pancreatic release. But the sulfonylurea is negative. I don't know how good it is, but that's probably the most common reason why the pancreas is secreting stuff without a stimulus. So sulfonylurea. What would be the other reason? An insulinoma. And insulinoma is right for this demographic. It's just that he's so otherwise, he has had so much else going on, but you have to think about it. The other reason that patients get autonomous insulin secretion from the pancreas is something called nesidioblastosis, and that is a diffuse growth of the beta-producing cells in the pancreas, though most commonly occurs after bariatric surgery, but is described de novo. So our short list so far is things that are not super esoteric. It's things like a sulfonylurea, with the pearl being that the sulfonylurea screen may not be perfect. It is that the patient has an insulinoma, or has nesidioblastosis, which usually is post-bariatric surgery. The last consideration is to think about what's called an insulin antibody syndrome. And that's where you form an autoantibody to insulin and prolong its half-life and prolong the half-life of C-peptide. And that was actually described in Japan because of a strong association with medications with sulfa in them. I think it was methimazole was the initial medication that was described when. And I'd be curious. What the pancreas deal is, because sulfonylurea seems less likely, and insulinoma is so rare. Nesidioblastosis is virtually unheard of outside bariatric surgery. So I'm wondering why this patient has this, and that's my four things: so sulfonylurea, nesidioblastosis, insulinoma, and an insulin antibody. But when you say those things and you have next to them sepsis and adrenal insufficiency, you probably should focus on the sepsis and adrenal insufficiency first. But an endocrinologist would be like, hey, listen, that C-peptide in the context of a glucose of 37 and that insulin is very abnormal. Don't forget it. Focus on the adrenals, focus on the sepsis, but come back to the pancreas eventually. That's where my mind is at. All right, Simone, back to you.
Okay, I will give you the last few drops of information and then ask you to put your nickels down. So the patient remained clinically well, but he was started on empiric antibiotics because of the bacteremia. The endocrinology service determined that his cortisol was sufficiently high that he didn't need to do a post-entropin test. He did not have any imaging on this admission, but he reviewed his prior imaging and found an abdominal ultrasound from the end of his last admission that said the pancreas is normal appearing and specifically had no focal or diffuse enlargement. And a TTE was done that showed an ejection fraction of 39%, down from 62% 3 months ago. There weren't any clear vegetations, but he did not get a TEE. And I will leave you with that.
Oh, sorry. Mouse almost stopped working. Kurtan, my friend, this has been quite a journey. What are your thoughts on the last bit of information?
I think the last bit kind of confirms what you said, that there has to be a component of endocrinitis. I mean, we don't see any vegetations, but since the blood cultures are there positive, we can consider the fact that sepsis might be contributing to it. And as the Rabi said, that sepsis and adrenal insufficiency clearly takes precedence over all that fancy thing that we talked about. And I don't know what else to make of it. I mean, LVEF of 39% also suggests that maybe the cardiac walls are not functioning properly. Probably there is component of systolic dysfunction, some sort. Diastolic dysfunction usually won't present as low ejection fraction. So this is clearly a case of systolic dysfunction. Now, we can always think that adrenal insufficiency can actually cause both dilated as well as hypertrophic cardiomyopathy. So amyloidosis can, of course, contribute to low ejection fraction. But apart from that, the sepsis is definitely there. We don't know how to rule it out, although the patient doesn't have fever. And I don't know what to add more. Can you help me out?
I have absolutely nothing to add. I agree. I think I'm worried about endocarditis in general, and also like in someone who has had previously so many different foci of infection. Are we missing any foci of infection? And there's other things that can help, like repeat blood cultures if they remain positive, all that jazz. So I would continue to investigate that a little bit more. But in terms of like the hypoglycemia, like someone in stage renal disease who is coming in with like bacteremia, is that enough to cause this degree of hypoglycemia? Like Robbie mentioned, that C-peptide is really, really bugging me as well. And I'm glad endocrinology evaluated for adrenal insufficiency. I don't know if like Robbie and Matthew have any other thoughts.
Matthew, what's on your mind? Anything to add?
Well, the low EF is a big problem. Like, I don't know how to fit it with I feel like you might end up with a couple of diagnoses. Like endocarditis shouldn't lower your EF that much. So now you have to, again, like come back to common things being common. If that in that patient demographic, he could very well have atherosclerotic disease, like common things being common. The other things you gotta wonder, if he's being like chronically septic, could he have developed a bit of septic cardiomyopathy, a bit of stress cardiomyopathy? But I feel the low EF is really weird.
You know, it's amazing what gravitates people's attention and what captures their eye. And I feel like streptomyces bacteremia in this context has to be at the forefront of everyone's mind in real life. And, you know, I feel like throughout my career in medicine, I've always made the disproportionate error of focusing on esoteria. And I got that feedback as an MS3. Like my attending was like, "Oh, you're doing a great job presenting, but please stop mentioning POEM syndrome in your presentations. Like, come on, this is a case of neuropathy, you know?" And if I'm being honest, I'm there. I'm in that same zone of I just can't shake how abnormal the C-peptide and this insulin is. My mind can't think about anything else. And in real life, I should probably be fired if I cannot think about this patient's low EF, streptomyces bacteremia, and all the things. But it's just so abnormal. It's so abnormal to have a C-peptide that I can't even think about the EF right now. And for me, it took me to a space where, like, you know, I've read these case reports of things that aren't sulfonylurea, but sometimes do cause sulfonylurea-like effects. And so I was looking through my files, and I found this case report in the American Journal of Medicine of Bactrim with the sulfa moiety acting like a sulfonylurea and mimicking sulfonylurea-induced hypoglycemia. And I completely agree with the dimension in this case. It has to be true that this patient has high risk for endocarditis. It has to be true that their K is an issue and their bicarb is an issue. But the pancreas, to me, is like, cannot be left off the hook. And so what's going on with the pancreas? I'm worrying that one of the medications that was recently initiating is having a sulfonylurea-like effect on this patient. You remember that our 4 checklist of necidioblastosis, insulinoma, sulfonylurea, and insulin antibody. Sulfonylurea is not just sulfonylurea. There's other medications that can do the same thing. And you know, the making extrapolations from tramadol and the recent initiation of it, I can't help but wonder if the methadone has part of the story here. But I don't know. Please, if you're taking care of this patient in real life, focus on their EF, focus on their streptomyces bacteremia, but maybe talk to an endocrinologist about this C-peptide and this insulin, and maybe they'll teach you something about either an insulinoma that can hide on ultrasound or necidioblastosis that can evade, that cannot happen post-bariatric surgery, or an insulin antibody syndrome, which usually is actually associated with multiple myeloma. But I'd be most worried about a med here, and a med looking like sulfonylurea. But I may get feedback from Simone, just like my attending in med school. Stop thinking esoteria and be rooted in common stuff. All that to be said, it was a pleasure hanging out and nerding out with you all, and I can't wait for Simone to teach us more.
Well, obviously, Robbie, you are, and everybody else is so brilliant all the time. And you're exactly right. The C-peptide and the insulin there's a lot of, just like folks who are immunocompromised can have a lot of things going on. Folks who use drugs also often have a lot of things going on. But here in this case, we were focusing on the hypoglycemia, and you're exactly right that the signal led us to the pancreas. And if we follow your #1 rule of time course, this hypoglycemia showed up for the first time as we up-titrated this patient's methadone on his prior admission. And continued to be problematic as he took incredibly high doses of methadone. And so the final diagnosis was, while obviously multifactorial, methadone-induced hypoglycemia. And yeah, Travis, I believe, sent out a paper really early on in this chat that methadone acts on pancreatic islet cells and in secreting insulin. And it's really interesting because it's not all opioids, it's just methadone. I mean, tramadol also, but like it's not oxycodone, it's not buprenorphine, it's just methadone. And so the recommendations of the endocrinology service were, don't chase down an insulinoma, don't do any more imaging, try to change him off of methadone, which he was not inclined to do. And so we just started giving him more snacks and the problem resolved.
I love this case. Simone, thank you so much. I'm always like just humbled by medicine and all the things that I have learned and all the things that I continue to need to learn. So I've never seen a case of methadone-induced hypoglycemia. So this is actually very informative. Thank you so much for sharing, Matthew, Curtin, you guys are brilliant. And RG, hey, you got it, friend. Thank you, Simone. Any other thoughts from the team before we pass the mic to Kiara for some awesome teaching points? All right, the wonderful Kiara.
Hi, thanks, Simone. Amazing case as always. And well, this was very great because hypoglycemia approach is very broad, as Kirtan told. So he told us that if we approach hypoglycemia, we first start like broad and then specific. So this amazing approach for hypoglycemia that you all work together was common how is that word? Common things are common. Yeah, that's the word. So insulin-mediated hypoglycemia was the most common thing, and this could be endogenous or not, or exogenous. Also, this hypoglycemia can be caused by chronic diseases, many chronic diseases like liver, alcohol, renal disease, endocrine or medication, endocrine disease with on medications, also end-stage renal disease. That Ravi told us that in patients with end-stage renal disease, insulin is not well excreted, so insulin tends to be high. And one other common cause for hypoglycemia is adrenal insufficiency. Also, we have to think about infection, inflammation, and drugs, like opioid abuse. And I remember Ravi telling us that he once read a case about methadone-induced hypoglycemia, and well, this was the case. So yes, also when we have hypoglycemia, this is a real emergency. So we have to think about life-threatening causes for hypoglycemia. The most common causes are sulfonylurea treatment, also sepsis, and adrenal insufficiency. And also, this patient was found with holosystolic murmur. So there were many questions for consideration with this. Maybe is this a new murmur? Is it due to osteomyelitis, bacteremia, or is there a risk for endocarditis and we have to perform a TEE? Also, this patient was found with hyperkalemia, and there are some causes of hyperkalemia like end-stage renal disease, adrenal insufficiency, or malignancy too. Then we have to think, as this patient was very likely to have an acute adrenal insufficiency specifically. So when we have an acute adrenal insufficiency, we have to have a big concern of sepsis, in this case like bacteremia that this patient was having. But there was one other question: do we have to attribute all these symptoms to bacteremia, or there was something else? So with acute adrenal insufficiency, this could be precipitated by some stressors like infection or bacteremia in these cases, and also persistent acute adrenal insufficiency or steroid therapy. Finally, you all noticed that C-peptide was elevated, but was elevated with hypoglycemia. That was a little weird. So what can cause C-peptide elevated with hypoglycemia. This could be sulfonylurea again, insulinoma, methadoneinduced, which is an excessive production of insulin by beta cells, insulin autoimmune syndrome, like that have trigger factors for like medication and infection. So finally, this case, as Simon said, it was multifactorial, and I love multifactorial cases because you have to think about everything and you don't have to exclude all. And I love that great approach and pearl from Simon, that we have to think to take medications first and see how the patient is going. So thank you, Simon. Amazing discussion, friends. Ravi and Charmin, love to see you today.
Ah, thank you so much, Kara. That was fantastic. Have a lovely day, everyone. Thank you. Bye.